Assalamu alaikum, it's me Dr. Muhammad Kazafi, and I'm just trying to present one more topic. It's a educational and informative lecture regarding the neurosurgery, and I chose today one topic. That name is Pilocytic astrocytoma. And as you know, the pilocytic astrocytoma are a low-grade gliomas, a family of the slow-growing tumor that arise from the glial cells, and they are most benign and most treatable of the gliomas, which with the cure rate of over 90%. So that's why I chose this, and I want to start with one thing here. So I am starting with with the name of the grace of Allah, and this is the pilocytic astrocytoma is the most common childhood brain tumor and most often found in the posterior fossa. Complete resection usually cures the patient. However, the patient can present with the brainstem compression and hydrocephalus, which are both potentially life-threatening. Therefore, it is essential to achieve early diagnosis and treatment. This activity reviews the evaluation and treatment of pilocytic astrocytoma and highlights the role of the interprofessional team in the care of the patient with this condition. Pilocytic astrocytoma, as an introduction, I want to mention here, previously known as a cystic cerebellar astrocytoma or a juvenile pilocytic astrocytoma, was first described in 1931 by Harvey Cushing and based on a case series of the cerebellar astrocytoma, though he never used these terms but rather described a spongioblastoma or spongioblastoma, and they are low grade and usually well circumscribed tumor which tends to occur in young patients by the World Health Organization classification of the central nervous system tumor. They are considered grade 1 gliomas and have a good prognosis. Pilocytic astrocytoma most commonly occur in the cerebellum but can also occur in the optic pathway, hypothalamus, brainstem, and they can also occur in the cerebral hemisphere. Although this lead to be the case in a young adult, presentation and treatment vary for the pilocytic astrocytoma in other location, and this article will discuss the pilocytic astrocytoma of cerebellum only. Glial cell include astrocytoma, oligodendrocytes, ependymal cells, and microglia. These glial cells all includes in the pilocytic astrocytoma, which I must say astrocyte definitely, oligodendrocytes, ependymal cells, and microglia. So, the tumors arise from the astrocytes. Astrocytic tumors arise from the astrocyte and are the most common tumor of the glial origin. So, in WHO 2016 categorized these tumors as either diffuse glioma or other astrocytic tumors. Diffuse gliomas include grade 2 and grade 3 diffuse astrocytoma and grade 4, which is called the glioblastoma, and diffuse gliomas of the childhood. And the other astrocytic tumors group include such as the pilocytic astrocytoma, pleomorphic xanthoastrocytoma, ependymal giant cell astrocytoma, and anaplastic pleomorphic xanthoastrocytoma. So these all which I mentioned, this grading system is histological, and it is worth noting that in 2016 WHO classification give more importance to the genetic and the molecular marker for categorizing the gliomas. However, pilocytic astrocytoma is essentially a histological diagnosis. I want to talk about the etiology, and there is a strong association between the neurofibromatosis type 1 and pilocytic astrocytoma. You have to remember this is a very important statement. There is a strong association between the neurofibromatosis type 1 and pilocytic astrocytoma, with up to 20% of patients with neurofibromatosis type 1 developing a pilocytic astrocytoma, most commonly in the optic pathway. And it is very important thing because it is about the 20% of the patient with the neurofibromatosis type 1, and these pilocytic astrocytomas are developing in the optic pathway. However, most pilocytic astrocytomas are thought to sporadic mutation rather than inherited, and BRAF gene alteration and MAPK and a signaling pathway alteration have been found in the majority of pilocytic astrocytoma. BRAF is a intercellular serine, or we can say threonine kinase, involved in the activation of the mitogen activated kinase, which is also called the MAPK, yani mitogen activated kinase, and the BRAF is a proto-oncogene mutation which have been found to cause human cancer. So this was the a little bit about the etiology, and now I want to tell you about the epidemiology. If I want to tell you about the epidemiology, you should consider that the brain tumor are the most common solid cancer in the childhood. And brain tumor definitely the most common I am telling most common solid cancer in the childhood, and the pilocytic astrocytoma is the most common childhood brain tumor with an incidence of 0.8 per 1000 people, and pilocytic astrocytoma most often present in the second decade of the life, with 75% occurring before the age of the 20 years. And pilocytic astrocytoma account for 15% of all brain tumor in children and comprise 27% to 40% of all pediatric posterior fossa tumor, and they can occur in adults, though typically in young adults. Pilocytic astrocytoma in adults comprise 5% of all primary brain tumor and is still often located in the cerebellar, but one case series found them most commonly in the temporal and parietal lobe. So these few statements are very important to remember that, and I want to mention in that manner that the brain tumor are the most common solid cancer in the childhood. And the second statement is that the pilocytic astrocytoma is the most common childhood brain tumor, and with an incidence of the 0.8 per 100,000 people, and pilocytic astrocytoma most often present in the second decade of the life, with the 75% occurring before the age of the 20 year. So the pilocytic astrocytoma account for 15% of the all brain tumor in children and comprises 27% to 40% of all pediatric post-fossa tumor, and they can occur in adults. So though typically in young adults, and when I am telling the posterior is 27 to 40% of all pediatric posterior fossa tumor, so then when pilocytic astrocytoma in adult comprise only 5% of all primary brain tumor and is still often located in the cerebellum, but one case series found them the most commonly in the temporal and parietal area also. Now I want to talk about the pathophysiology. Pilocytic astrocytoma to occur close to the midline, although in an adult, and it can be more lateral within the cerebellum. So the pilocytic astrocytoma can occur anywhere within the neuroaxis, and that's why you can appreciate here it is present in the neuroaxis anywhere, and you can appreciate very well with this picture. So as you know, the cerebellum is 42% to 60%, optic glioma or the hypothalamic glioma, it is 9 to 30%, which is the most common site of the pilocytic astrocytoma if associated with the neurofibromatosis type 1, and brainstem is 9%, and I must say spinal cord 2%, cerebral hemisphere in young adults also. And so the histopathology, I want to talk about little bit about the histopathology of the tumor. Regarding the histopathology, pilocytic astrocytoma is a WHO grade 1 tumor, and there are the case series of the anaplastic pilocytic astrocytoma with uncertain behavior and microscopic feature. So the pilocytic astrocytoma get its name from the microscopic appearance of the cell with long, thin, bipolar processes that resemble hairs, and which is called this pilocytic. And these are often Rosenthal fibers, and which are elongated eosinophilic bundles that are found on hematoxylin and eosin staining. Pilocytic astrocytoma have low to moderate cellularity, and multiloculated giant cell with peripheral nuclei can be seen, and tumors that have been present for a more extended period may have hemosiderin-laden macrophages and calcification. An area of necrosis may be seen, though exceedingly rare. So, though they are radiologically described as well circumscribed, nearly two-thirds infiltrate the surrounding brain parenchyma, and histological architecture shows the pilocytic astrocytoma frequently breaks through the pia and breach into the subarachnoid space, and they can infiltrate the perivascular space. So the microscopically it can be challenging to differentiate between the pilocytic astrocytoma and low-grade diffuse astrocytoma. For this reason, and the pathology team need to have demographically and radiologically information available to guide the diagnosis. A small biopsy sample also compose the diagnostic issues. If I want to talk about the molecular features, the most common genetic abnormality found in 70 to 75% of pilocytic astrocytoma is BRAF gene alteration. BRAF alteration are more common in pediatric pilocytic astrocytoma than in adults, and pilocytic astrocytoma have alteration in MAPK signaling pathway in more than 80% of cases. So, as you know, that KIA and BRAF fusion is the most common identified mutation in pilocytic astrocytoma. Immunohistochemistry shows positive for the glial fibrillary acidic protein, S100 protein, and oligodendrocyte transcription factor. Importantly, as with other pediatric low-grade glioma, they are negative for isocitrate dehydrogenase and tumor protein P53, or we can say the mutation. All you can see. That's why I chose this this picture to explain you. There is a BRAF gene, and it is the alteration when happen here, and then this cancerous cells has been developed, and then they cause the make the pilocytic astrocytoma. Here you can appreciate by a picture. There is a brain in the cerebellum. You can see this disassociate, and then immunolabel you can see here, and there are the SOT cells, and here the molecular biology, you can understand the input signal cell RNA, and in the BRF you can see the first strand synthesis. They are the poly T oligo, and then they are the 3BRF oligo, and the conversion here, and then you can see the alteration happen at the BRAF. You can see it is showing in the red, and then template switching extension, and you can appreciate here how it behaves. Regarding the history and physical, pilocytic astrocytoma are present with symptoms secondary to the posterior fossa mass effect, and this may include the obstructive hydrocephalus with resultant headache and nausea and vomiting and papillary edema. If hydrocephalus occur before the fusion of the cranial suture, means the less than 18 months of age, then an increase in head circumference will likely occur. So I want to mention here that the pilocytic astrocytoma are present with the symptoms secondary to the post fossa mass, and this may include the obstructive hydrocephalus with resultant headache, nausea and vomiting and the papillary edema. And if hydrocephalus occur before the fusion of the cranial suture, it means if it is less than 18 months of age, then an increase in head circumference will likely occur, and the lesion of the cerebellar hemisphere result in peripheral ataxia, dysmetria, intention tremors, nystagmus, and the dysarthria. In contrast, lesion of the vermis cause a broad-based gait or the truncal ataxia and titubation, and the post-fossa lesion can also cause cranial nerve palsy, and diplopia may occur due to the abducens palsy from the stretching of the nerve. They may also have blurred vision due to the papillary edema. Seizures are rare with posterior fossa lesion. Regarding the evaluation, so I was just telling that regarding the evaluation, the investigation of choice in the brain is a magnetic resonance imaging with contrast, and I have shown you deliberately this picture, which is the MRI with contrast, and you can appreciate the vasculature here, both middle cerebral arteries, you can appreciate, and sinuses which with the contrast in the MRI, and you can appreciate that this also avoid radiation exposure. And however, if the children in the neurological unstable and urgent head CT scan with contrast is indicated, and in clinical practice, children with the post-fossa tumor tend to get whole neuroaxis imaging as a more malignant tumor type can form a drop mets, so the pilocytic astrocytoma do not form the drop metastasis like ependymoma and medulloblastoma, and theoretically would not require whole neuroaxis imaging. And it is important to note that the variant pilomyxoid astrocytoma is more aggressive and can form drop metastasis. Spinal seeding or leptomeningeal dissemination is extremely rare in pilocytic astrocytoma. Therefore, it is the only recommended in suspected or certain cases. Pilocytic astrocytoma can have a multiple radiological appearances in 66%, and there is a significant cystic component with avidly enhancing mural nodule, while in 46% the cyst wall also enhance, and you can appreciate here, and in up to 17% of the cases the tumor is a solid with minimal or no cystic component. Up to 20% may show calcification and in 17% of cases the tumor is solid with minimal or no cystic component, and up to 20% may show calcification. So pilocytic astrocytoma is periventricular in 82% of the cases, and the cyst content in proteinaceous and thus in often denser than in cerebrospinal fluid. On MRI, the mural nodule is hyperintense on T2 weighted image, an ISO or a hypointense on T1 weighted image, and the cyst content, or we can say the cyst content, show a high signal on the T2 image and similar to the CSF. So as described I previously, the nodule is avidly enhancing, which is used to differentiate from the. So this I want to mention the cis content show a high signal on T2 image similar to the CSF as described above. The nodule is avidly enhancing, which is used to differentiate from the low-grade gliomas. Regarding the treatment and management option, the mainstay of treatment is surgical excision with the aim of complete resection margin while achieving a minimal neurological injury, and complete resection is considered curative for the disease. However, the involvement of the brainstem or cranial nerve may prevent complete resection, and the resection of only the nodule and not the cyst wall is recommended. However, tumor with the thick cyst wall can be considered part of the nodule and thus removed. So the conventional radiotherapy is not required. Instead, follow-up with the serial imaging is more appropriate, and the radiotherapy, particularly in this region of brain, carries significant sequelae, and if there is a recurrence, then further surgical resection is typically adopted. Radiotherapy may be appropriate if surgical unresectability or if malignant histology is present. In some studies, stereotactic radiosurgery gave excellent result for residual and recurrent tumor. Although there have been criticism regarding the duration of the follow-up in these studies, there is some concern that the stereotactic radiosurgery may encourage the anaplastic transformation, and this is a very difficult to accept by any physician or the patient. Management of the hydrocephalus approach for the neurologically well patient. Here I want to mention, as I mentioned, that the management of the hydrocephalus approach for neurologically well patient, CSF diversion at the time of surgery followed by the immediate tumor resection is very important, and surgical resection without CSF diversion. If hydrocephalus persists postoperatively, then perform the CSF diversion. So surgical resection without CSF diversion, and if hydrocephalus persists postoperatively, then we have to perform. So usually people are performing that before it can cause a significant neurological issue for the patient. CSF diversion around 2 weeks before definitive surgery, and if patient is neurologically unstable due to the hydrocephalus or brainstem compression, the urgent intervention is warranted. And if the presentation is with hydrocephalus, some author advocate initial CSF diversion before definitive surgery using an external ventricular drain or endoscopic third ventriculostomy or ventriculoperitoneal shunt. Some center will place a external ventricular drain or perform an endoscopic third ventriculostomy at the time of surgery, followed by immediate definitive tumor resection. However, some advocate that the CSF diversion should be around 2 weeks before resection. And disapproval for the approach is that the placing a ventriculoperitoneal shunt generally commit patient to lifelong shunting and complication. Also, tumor sending may occur into the peritoneum, although this is a rare and can be mitigated by the placement of the tumor filter on the shunt system. Surgical factors to consider with the CSF diversion include possible upward transtentorial herniation and CSF infection due to the ventriculoperitoneal shunt, or I can say that external ventricular drain contamination. So some critique that or some criticize that this method caused the unnecessary delay for the definitive treatment. So that's why, in my humble opinion and in my humble practice or in my humble experience, I am interested if that kind of a patient, such as that patient, pilocytic astrocytoma, I want to put the VP shunt or EVD or an ETV just to divert the CSF. Because when we are doing that surgery, definitely it is giving, but there the counter argument are there also, and we respect these counter argument that it has other things. So I don't want to go here and there, and I want to talk about the differential diagnosis. So regarding the differential diagnosis here, the most common pediatric posterior fossa tumor, medulloblastoma, typically midline, I can say on the roof of the fourth ventricle, vermian, and less than 10% have the calcification. Second is I'm just talking about the most common pediatric post fossa tumor. So medulloblastoma definitely, and then I want to put the diffuse pontine glioma, usually multiple cranial nerve palsies here, and ependymoma usually arise in the floor of the fourth ventricle, and calcification is common. One pediatric post fossa lesion, clinical and the radiological differential I want to mention here, which is the hemangioblastoma, atypical teratoid rhabdoid tumor, and cerebellar abscess or the choroid plexus papilloma, metastasis, especially medulloblastoma, rhabdomyosarcoma, Wilms tumor are also. So these are the two different I want to mention here. There are the two different I want to mention here that the most common pediatric post fossa tumor is the medulloblastoma, diffuse pontine glioma, and then ependymoma. Ependymoma in the floor of the fourth ventricle, and then calcification. But the pediatric post fossa lesion, such as other than this, is hemangioblastoma or atypical teratoid or rhabdoid tumor, cerebellar abscess, choroid plexus papilloma, metastasis, neuroblastoma, rhabdomyosarcoma, Wilms tumor. So in adult post fossa tumor, if I consider, then I will put the metastasis, which is the most common in the post fossa of adult, and hemangioblastoma, about 7 to 12% of all posterior fossa lesion in adults, and the brain stem glioma, abscess, cavernous ball formation, ischemic stroke, cerebral hemorrhage, or all could be here. So for the adult, we make a list little differently, like the metastasis first, then hemangioblastoma, then the brainstem glioma, abscess definitely, cavernous malformation, ischemic stroke, cerebellar hemorrhage. And here I want to mention for you, there is the pilocytic astrocytoma is a slow growing tumor that is often curative on resection. So the best prognostic factor is a total resection, and survival rate at 10 years is approximately 25% if complete resected, and the recurrence is rare if complete resection is achieved. Those that do occur tend to do so within a few years, which is the Collins law state that the period of the risk of the tumor occurrence at the age of the child is diagnosis plus 9 months. So when we are diagnosing and then plus 9 months, it is the we can say this is the Collins law, and it is nowadays very popular and people are mentioning it. So using this concept, pilocytic astrocytoma can be considered cured if it does not recur within that time. However, there are documented cases of late occurrence, and if there is an incomplete resection, recurrence may occur with progression of symptom, and risk factor for the recurrence have been identified, including solid tumor, exophytic component, and the tumor invasion. For pilocytic astrocytoma in adults, the several at 5 years in 85% and progress free in 70%. So the tumor recurrence in adult case is approximately 20%, and the patient younger than 1 year have the worst diagnosis. However, this is possibly due to the variant pilomyxoid astrocytoma, which most commonly occur in the early age. For complete removed tumor or maximum of 3-year surveillance, imaging is recommended due to the minimum risk of the recurrence in pediatric pilocytic astrocytoma. I want to talk about here little bit the complications. So complications are related, as I mentioned, the patient with the post-fossa tumor may develop hydrocephalus and requiring a VP shunt. If so, they will likely to the shunt dependent for life, though recurrence is usually amenable to further resection. Some pilocytic astrocytoma shows malignant degeneration, though this is rare, and most of cases with malignant degeneration seems to follow radiotherapy. Deterrence and patient education, it is very important. There are no modifiable risk factor at pilocytic astrocytoma. Some genetic conditions such as the neurofibromatosis type 1 predisposing or predisposed familial to the pilocytic astrocytoma, and therefore the genetic testing and counseling may be the appropriate. However, most pilocytic astrocytoma are due to the sporadic mutation. Pilocytic astrocytoma is most common pediatric brain tumor, as I mentioned, and classified in a WHO, as I mentioned, as a grade 1, and MRI typically cystic with the vividly enhancing mural nodule, although can be completely solid and microscopically long bipolar cellular process that look hair-like. Excellent prognosis with the complete surgical resection, radiotherapy and chemotherapy, and not routinely used. So 95%, or we can say the 95% patient, 10-year survival with surgery alone if complete resection, but a strong association with the neurofibromatosis type 1, and 5 to 20% of patients with neurofibromatosis type 1 develop pilocytic astrocytoma, mostly in the visual pathway, especially the hypothalamic area and the visual pathway area. So the presentation typically with the cerebellar side and the feature of hydrocephalus. Patient may require CSF diversion, and I have talked about in detail previously. Pilocytic astrocytoma is most common pediatric brain tumor, as you know, and require urgent assessment and management. So they should be considered a chronic disease, and this patient is still initially present to the pediatrician or emergency clinician or general practitioner. Therefore, these clinicians must recognize sign and symptom of mass affecting the cerebellum or brainstem, include the clinical presentation of hydrocephalus. So I want to present one case as usual for the analogy, so we can understand how practically we are dealing with that case, and how patients are presenting to us, and how we are responding to them. So one patient is a 10-year-old male who present with the 4-month history of the headache without vomiting, and a 4-week history of a difficulty with balance, and his family report some weight loss over the past several weeks, and he spotted being able to ride a bicycle or a skateboard about a month prior to admission, and report behaving, we can say, because having been very tired for the past couple of weeks and have been sleeping a lot during a day, and despite this he continued to do well in the school, but he has had no nausea and vomiting. There are no report of the seizure, syncope, and bowel or bladder changes, and by report he was shopping on the day of admission when he developed problem with his vision, which prompted a visit to the emergency room by his grandmother. A head CT scan was performed and showed a large cyst in the post fossa with associated mass effect and the occlusion of the fourth ventricle. So the complete effacement of the basilar cistern and marked enlarged lateral and third ventricle with associated transependymal flow. An MRI of his brain noted to contrast enhancing mass in the posterior fossa within the large cyst. So the differential diagnosis with us, as I mentioned before, definitely is a small child. Definitely, if I say if I say the pilocytic astrocytoma, then I must say the medulloblastoma, then I must say the ependymoma, then I must say the atypical astrocytoma, or I can say the post fossa glioma, and must say definitely either the hemangioblastoma or the rhabdoid or the teratoid tumors. So then and I take this picture from the book, and it is very important to me. Yes, I took this picture from a book. Here you can see there the post fossa tumor, cystic lesion, MRI showing the sagittal, axial, sagittal, axial images and the coronal image. And here you can appreciate, if I mention from the sagittal, you can see there is a cystic lesion in the posterior fossa with the dilatation of the ventricle. It is showing in the T1 weighted image, and there is a T2 weighted image, or the diffusion enhancing image. Here you can see the seepage of the CSF into the frontal horn and the occipital horn in the axial image, which is showing in the B. And in the C you can see there is a MRI coronal image which shows there is a hyper intense enhancing lesion in contrast, and you can see in the post fossa and the dilatation of the ventricle. It's a post contrast scan of the coronal image, and in the axial image, which is the dilatation of the both lateral ventricle with third ventricle, and the lateral ventricle showing the temporal horns and showing the Mickey Mouse appearance in the frontal horns, and the ballooning of the third ventricle with the significant obliteration of the fourth ventricle because of the cystic mass in the posterior fossa with the mural nodule, which is enhancing with the contrast. And so this is the description, and here this is the present. So you can see here the MRI of the brain with or without contrast, and documented that this lateral or the third ventricle are moderately enlarged, and the fourth ventricle is nearly complete affected, or interstitial edema can be seen within the white matter of both cerebral hemisphere. A large cystic and the solid mass arise from the left cerebellar hemisphere, extending from the territorial incisura to the foramen magnum, and the mass measures slightly less than 6 centimeter is maximum dimension, and demonstrate an enhancing solid mural nodule and a thin enhancing rim. Basal cistern and the fourth ventricle are nearly completely affected, so the cerebellar tonsils are inferiorly displaced, and the signal characteristic of the brain are otherwise normal. So though no other extraaxial, intraaxial masses are identified, and normal intracranial vascular flow void are noted, and the radiological differentiation diagnosed include the benign or malignant post fossa tumor. Benign brainstem tumor is favored by the long history without multiple cranial nerve involvement, a respect of the boundaries of the medulla and the medullary location as opposed to the pontine location, and benign masses in this location can include the pilocytic astrocytoma. Less likely diagnostic include the hemangioblastoma, pleomorphic astrocytoma, and the brain abscess. But the malignant tumor in this location include the anaplastic astrocytoma, glioblastoma multiforme, metastasis, and the lymphoma. So once they, then definitely this patient has been admitted for now for the definitive treatment, and or the we can say the some kind of a trial for the or means a good trial, a strong trial for the definitive treatment, and the laboratory investigations done, routine labs, ESR, CRP to exclude any infection, and the imaging done as I mentioned, CT brain with and without contrast, then MRI brain with and without contrast, and the slice cut to utilize for the we can say the intraoperative stereotactic localization, and MRI brain with or without contrast, a full whole neuroaxis. Definitely we have to check maybe because the medulloblastoma can metastasize in the neural axis. So the biopsy versus resection, if I consider biopsy versus resection, so giving the probable benign nature of this lesion, we recommend craniotomy and complex resection or complete resection of the lesion with the neural nodule. So as you know, as I mentioned, if I consider the pathophysiology of my patient, you know this is a juvenile pilocytic astrocytoma, is a low growing, often cystic and generally circumscribed astrocytoma affecting children and young adults, and it is characterized by the Rosenthal fiber. So the loose multipolar cells and the eosinophilic granular bodies, and this pilocytic astrocytoma is the most common astrocytoma. Approximately 15% of patients with the neurofibromatosis type 1 and develop pilocytic astrocytoma. So gain have been I say observed in chromosome 7 and 8 in a third of the pilocytic astrocytoma. In addition to the cerebellum, pilocytic astrocytoma can arise in the optic nerve, and the optic nerve glioma or the chiasma glioma or the chiasmal glioma or the hypothalamus glioma or the thalamus glioma or the basal ganglion glioma, brainstem glioma or the cerebellar hemisphere or spinal cord, which I mentioned earlier. And as I mentioned, for my patient, this is a clinical feature and symptom all depend on the location, and post fossa pilocytic astrocytoma most often have a sign and symptom of the raised intracranial pressure, of hydrocephalus, headache, nausea, vomiting, increased head circumference, giving the effacement of the fourth ventricle. Truncal ataxia is also common in midline lesion, and optic pathways can be associated with the vision loss or the proptosis. So although rare, but the leptomeningeal domination of the I want to mention here the pilocytic astrocytoma may occur. Those with the hypothalamic tumor appear to be at the greater risk for the dissemination. And as I mentioned here, there is a treatment option, and you know there is a surgical gross total resection of pilocytic produce the best cure rate. Otherwise, mass debulking and or we can say the subtotal removal, we do not recommend the percutaneous cystic drainage or biopsy or stereotactic. I want to go for the complete resection of the tumor. Radiotherapy and chemotherapy. Radiotherapy is usually considered a final option in tumor with multiple recurrence, where further surgery would be associated with significant morbidity. Chemotherapy is an agent has been not to proven to be useful in the treatment of these tumors. But the surgical technique I want to mention here. So regarding the surgical technique for posterior fossa approach, are preferred to position the patient in a lateral position. If the tumor is in midline, we usually position with the right side up. Otherwise, position the patient with the tumor involving cerebellar hemisphere side up, and this patient was placed in a lateral position with the left side up. So prior to the position, place a Mayfield head holder. Once position, enter the stereotactic coordinated, and then stereotactic coordinate should apply, and the head is flexed with the patient chin resting approximately 1 to 2 centimeters from the chest. Flip the patient hair solely around the incision side, and we prefer to make over initial incision using pinpoint, monopolar, electrocautery, or cut setting, and any scalp bleeding at this point is addressed with the bipolar coagulation for lateralize the tumor, and we position our incision so they directly over the lesion. Otherwise, we utilize midline incision. In this case, incision was lateralized over the tumor and it is self-retaining retractor were placed and the craniotomy performed to allow for a direct approach to both the enhancing mural nodule and the cystic tumor component. In this scenario of the right cerebellum, a ventricular catheter can be placed into the cyst to reduce the pressure for midline approach, and we take the incision down through the underlying muscle in the midline and specifically a avascular midline. I want to mention here avascular midline raphe, and the inferior extent of this incision is just below C1 and the superior extent, usually ending approximately 2 to 3 centimeter above the foramen magnum. Once the foramen is identified, so free the underlying dura circumferentially from the confines of the foramen, and we have found that widening the foraminal, I can say the aperture, and using a high speed drill and facilitate over approach. So these allow for the introduction of the craniotome, which we prefer for the post fossa bone flap in children, and following during closure, the flap can be repositioned in the midline using a titanium plate system. And we additionally use the craniotomy to perform a laminectomy at the C1 level, and the dura is often opened in a Y-shaped fashion with a no I mentioned here when you are making the Y-shaped fashion, or it is not a compulsion. You can make in a cruciate fashion also. It's up to you. But Y-shaped, I deliberately use this because I am usually doing with the Y shape, and I am using here the 11 blade scalpel. Few people are using the 15 blade. I am comfortable with the 11 blade and surgical scissors, and then the dural leaves have then be reflected laterally and superiorly, and using I want to mention here intrasurgical scissor, and then dural. And I want to mention here, we can hold with the nylon suture this dura, and we prefer to use the malleable retractor arms that attach directly to the Mayfield pin and headset, and which is also, I can mention here, it is a Fukushima type to minimize culture into the operative field. And giving this approach, we are able to minimize manipulation and or resection of the vermis while maximize our operative. In general, the tumor nodule are we can say the grayish in color and somewhat gelatinous appearance. And the ultrasound aspirator can readily discrete between tumor and the normal cerebellar parenchyma, and once tumor has been removed, all tumor margin need to be visualized to verify a complete resection. And the couple visualization of surgical cavity with the lining of the cavity using surgical to prevent post-operative clot formation. And in pilocytic astrocytoma, the tumor cyst is drained at the time of surgery, but does not need to resect. Does not to be resected. So I want to mention here the tumor cyst is drained at the time of surgery, but does not need to be resected. And the cautery is true. I think in contrary is true for the cystic anaplastic astrocytoma. With either approach, watertight dural closure, either with or without graft, is a ultimate goal, and we do not agree with the approach of leaving the dura open to allow for the pseudo meningocele formation and facilitation of the future surgeries. So, in approach should be done in the lateral position, as I am preferring lateral position with the neck little flexion, means 20 degrees, 30 degrees, and the use of the suitable pediatric head frame to stabilize the head of the surgery and obtaining accurate neuronavigation information is essential. It's very essential in that regard that multimodality evoked potential monitoring can be utilized with midline lesion for lateral approach may be required for the large anterior lesion and for the lateral growth. So, in a presumably acceptable and distinct appear tumor, complete resection is the primary goal. And in the scenario of juvenile pilocytic astrocytoma, the cyst wall non-enhancing do not need to be resected because they are displaced from the cerebellar parenchyma. And if the cyst wall enhancing thickly resection is necessary. In large tumors with significant extension into the cerebellopontine angle and anteriorly, a staged approach to minimize morbidity may be the best option. Complication I want to mention here, endoscopic resection is an option, and nowadays a lot of expertise has been introduced, and they are offering the endoscopically removal of the pilocytic astrocytoma, and they are doing very well, although but either we are doing the endoscopically, either we are doing the open surgical technique. We have to perform very discreetly and try to excise the tumor because it's a grade 1 WHO tumor. We have to remove it properly, and because if we remove the properly, then we can promise some result with the patient. Otherwise, we won't. Now, right now, I want to present you few complication. This picture not related to the complication, but I want to mention you about it was only related to the endoscope, and now I want to mention the complication. So I was mentioning here intraoperative blood loss or should be minimized throughout the procedure, and aggressive use of bipolar electrocautery for muscular bleeding and the bone wax for the bleeding help maintain to dry field. In young children, the C1 lamina is partially cartilaginous, and thus subperiosteal dissection may not be possible, so it is also incomplete fuse in the midline, so care must be taken not to accidental open the dura during the laminectomy. Coagulation of the dural venous channel before cutting not only provide good hemostasis but also decrease the possibility of air embolism. If briskly venous bleeding is encountered during dural opening, a small titanium vascular clip and you can apply and provide a useful tool to control the bleeding. Sometimes you try to suture micros and take a time, and you can able to do that. Definitely you are a neurosurgeon and you can do that. So during the procedure, the reflected dura flap should be copiously and frequently irrigated to prevent drying and shriveling of the dura. So the post-operative, post-resection hydrocephalus, endoscopic third ventriculostomy or ventriculoperitoneal shunting, don't hesitate. It is not a shame if patient need potent pseudomeningocele formation and the CSF leakage could present, so revision of the dural closure you have to do. Wound closure, CSF shunting or lumbar CSF drainage may be required and it may work. So the post-operative pneumocephalus increase in inspired oxygen concentration to 100% using a non-rebreathable mask temporary, and the patient should be flat. So the post-fossa syndrome, cerebellar mutism or akinetic mutism, high dose steroid, maintaining adequate mean arterial pressure and rehabilitation, it will help you to solve the problems or the complication. So I try to mention you about this case as much as possible to make you comfortable, and collectively I tried to explain in a very simple manner. I hope you will like it. If you like it, please subscribe it, share it, and support us. Thank you so much.